Most of the patients come in because they know about it. They've read about a brochure, they've seen it on TV, they've heard about it. Sometimes their kids mention it, but it's I would say mostly it's the patients that are pushing it.
I think everyone has a different outlook on what they're looking for. For some people, if they're short of breath, they just want to be able to breathe easily. If their quality of life is pretty dismal, they don't want to live in terms of quantity of life. They just want to get some of that quality back.
They know about valve surgery. They want to know is this kind of equivalent? Will this be able to help them? Most of them do not want to undergo valve surgery at this point, open heart surgery, because they're older, they've had valve bypass surgery before, and they want to know whether it's going to help them or not.
The ages of our patients ranges from a youthful 55 to as old as 99.
The 99-year-old was pretty alert and intact and was editing a book. In terms of what the TAVR is, we basically use a balloon to open up the valve initially, and then this is a stent with a valve sewn inside it. And it's the same sort of valve that's used in surgical valve replacements. It's a cow pericardial valve that's created inside the stent, and the balloon is inflated across the aortic valve, and the stent is deposited in the annulus and pushed back into the annulus, and that's where it's anchored. And once it's in, it's rigid. It's in there. It's not going to move. And it basically has very good pressure. We call it hemodynamics, but the pressure dropped across the valve is only maybe 8 to 10 millimeters of mercury, which is very good. Surgical valves oftentimes will be 10 to 15 or 10 to 20 millimeters of mercury. So the lower the gradient, the more normal it is. And the valve works well. The concerns we have are how much leak there is around the valve, and that's something we're very hard to reduce that leak, and that it's positioned well. And then they're on antiplatelet medication for usually 6 months to a year afterwards to try to reduce the risk of stroke, which is really pretty small.
People are in the hospital for 4 to 5 days, sometimes a little longer depending upon their individual progress. We generally tell them that we would prefer them not to drive for 2 weeks until they come back to us for their first post-operative visit. Usually by then they can begin to gradually increase their activities back to what was their baseline. And I encourage them to not be couch potatoes anymore.
We rotate the delivery of the valves, so sometimes it's the cardiologist, positioning, and the surgeon inflating. Sometimes it's the other way around. And the interventional cardiologists rotate their roles, and the surgeons rotate their roles, and everybody sees the patients in clinic. This has been a very good experience for us. I think the surgeons and the cardiologists understand what each other does, have new respect for the work that they do and the difficulty of the work that they do. And it's been a very good team-building relationship. I think we've gotten closer as friends, and I think we work better together. So it's been very good.
For many, they've had a very full, productive life, and they're still feeling that they're that youthful person inside a body that's letting them down, and so they just want another lease on life. And this is it.